You start to record. But I think, as you have read, the discussion today is going to discuss cataracts and macular degeneration, two eye conditions that occur frequently as we age. He is an associate professor of ophthalmology and visual science at the University of Chicago and provides comprehensive care for a wide range of eye conditions. He has a particular expertise in diagnosing and treating patients with cornea and external eye diseases, including viral infections of the cornea. And so with that, we welcome you. We're delighted to have you here to share with us, and we'll turn this screen and whatever you need over to you.
Thank you very much, and thanks for having me. I'm gonna share my screen and put my slides up. Okay, so you should all be able to see my screen, yes?
Yes.
Okay, perfect. So again, my name is Asim Farooq. I'm a faculty member in the Department of Ophthalmology and Visual Science at University of Chicago. And my areas of focus and expertise are corneal diseases as well as cataract. And today I'm going to be talking about the aging eye. And I will go over a cataract and macular degeneration, but I did include in this talk some slides on glaucoma as well as diabetic retinopathy. After we initially decided on the topic, I thought that it might be good to include those things because they're also things that we see commonly, and I thought it would be good to spark some discussion as well. All right, so first I'll talk about cataract. So what is a cataract? This is a cloudy, opacified, crystalline lens that's located inside the eye. Now, in general, the lens inside the eye is clear when we're all born. Now, there are exceptions, but for the most part, the lens is clear. And over time, over the years, the lens gets a little bit cloudy. There are many different types and severity of cataract. And so a couple of the images that you see here, these are very advanced cataract, what we call a white cataract or mature cataract. You could see these from across the room, and patients with this severe of cataract can't really see much out of the eye. So this is not the most common scenario. It's rather uncommon, but we do see this. I probably take out a cataract like this once every couple of weeks. So what are the associations? Age is the most common. A lot of patients come in and they say, is cataract hereditary? And the answer is yes, it can be, but that's a very small minority of cataract. For the most part, everyone gets cataract at some point in their life. There are other associations, including diabetes as well as trauma. People that have had eye injury, for example, they may get a cataract at a younger age than they would have otherwise. So what are symptoms that patients may experience? These include blurry vision that's present all the time or most of the time. And then there's difficulty with activities of daily living, including reading or driving, watching TV. And one specific symptom that a lot of patients describe is glare from oncoming headlights. So driving, especially at night, becomes a problem. So how do ophthalmologists make the diagnosis of cataract? This is done in the clinic using a microscope that we use called a slit lamp. And we also measure the vision. And in fact, we measure what's called the best corrected visual acuity. In other words, when you come into the office, we see how good does the vision get if you were to get a new pair of glasses. So for example, if the vision's kind of blurry and a patient comes in And with new glasses, their vision is 20/20, and they say, hey, everything looks sharp and I can see. Then you might have a cataract, but you don't need to have it out at that moment. So we use the exam and also the vision measurement or the glasses measurement to determine if a cataract is quote unquote visually significant. In other words, yes, there's a cataract there, but is it causing problems beyond just the need for glasses? So say we've done those steps and we've determined together that a cataract is visually significant and it's impacting activities of daily living, including reading, driving, etc. So the main way to treat this is cataract surgery. And that involves removal of the opacified lens. And that is generally, and I would say generally in nearly every case, it is replaced with an artificial lens implant. Cataract surgery is one of the most common surgeries performed in the world. More than 3 million cataract surgeries are performed in the US every year. Patients are typically in their 60s to 80s, but again, some are younger and some are older, depending on individual circumstances and decision making. So again, not all cataracts need to be removed, and the decision for surgery is made between the surgeon and the patients, depending on the patient's vision experience and vision requirements. So for example, somebody who is in their early 60s and drives 30 minutes each way to work, their vision requirements may be different from someone who doesn't drive but enjoys reading versus someone who likes to crochet or do other types of fine needlework. Everyone's vision requirements are different, and the decision should be based on that. So I always, when a patient asks me, do I need to have the cataract out, I usually kind of throw it back and I say, well, what do you think? Do you think you can do the things you need to do, and can you do them to a satisfactory level? And if the answer is, well, not really, I'm having some trouble, and I say, okay, well, then maybe it's time for you. And if you think you want to go through it, then let's talk about it some more. So now there may be other things going on in the eye that are also influencing vision. So sometimes we remove cataract, but there's another issue at the same time. So we always talk about that removing the cataract should improve the vision, but in those cases, it may not make it perfect. So again, it's a very individual decision as to the timing of cataract surgery. I don't know if the group has interest or the stomach for watching a video of cataract surgery. Yes, does anyone want to watch it, or no? It's just a minute or so.
I say go for it, and we can close our eyes if we don't want.
Okay, sounds good. So let's see, hopefully this plays. I'll put this on mute. So I just want to give you an idea, so we've operated through very small, tiny incisions in the eye. Again, please close your eyes if this makes you feel unwell. But the yellow thing in the pupil is the cloudy lens. And this is microsurgery. So we make a very tiny opening in the capsule of the lens. And I'll kind of speed it along here. We put some fluid, and then we use a device. It's an ultrasound device. And that breaks the lens up into pieces and suctions it out. I'll move things along here. And so you'll see that yellow stuff is coming out of the eye. Okay. And it's being suctioned out through this ultrasound tip very, very efficiently. Okay, so that yellow stuff is coming out. And it's almost out now. And look how clear it looks. Now you can tell how yellow that cataract was. And now there's going to be an artificial lens placed into the eye. And this is a lens made out of acrylic. It's a type of plastic. And that lens has a power, and that power gives the eye the ability to focus. And so generally, patients don't really need glasses to see far away. They often need glasses for reading. But you may have heard from people, or if anyone's had cataract surgery, that it should reduce the dependence on glasses, at least for far away. So so that's kind of a quick video illustration of cataract surgery. I do about 50 of those every month, 40 to 50 every month. And it's a surgery that I really love doing. I wanted to take a moment to talk about intraocular lenses. So you saw in that video, or some of you may have seen in that video, that an intraocular lens was placed. And so when a cataract is removed, that lens allows the eye to focus. And there are different types of lenses. And the type of lens that a surgeon will recommend is based on the patient's individual needs. And now we don't place the lens on the finger like that, but this picture just kind of illustrates the size of the lens. And the illustration on the top right kind of shows the lens going in, being injected into the eye, which you just saw in the video. So I wanted to kind of go over just a couple different lens types. There are more lens types, but I think that this is a kind of a good way to understand the overall decision-making process. And so the vast majority of my patients get what's called a monofocal lens. Mono, of course, meaning one, focal meaning point of focus. And a monofocal lens has a single point or single distance at which it is most focused. Now, usually patients will select to be in focus and distance so that they can see far away. So for example, so that they can drive without needing to put on glasses, etc. They can watch TV, they can read the clock on the wall, they don't need to put on glasses. Those patients will need reading glasses. Now there is another option, which sometimes we go for, in which one eye is set as the far away eye and one eye is set as the close-up eye or the reading eye or the computer eye. And this is something called monovision. Not all patients go for this. It's a minority in my practice. And I don't think it's a good option for some patients because it can affect depth perception a little bit. But for patients who want to have good quality of vision and reduce their dependence on reading glasses a little bit of a offset difference between one eye and the other eye can help to increase the range with which you can use your eyes without needing glasses. A monofocal lens has the best quality of vision. It provides the most vivid colors, the greatest contrast, and the ability to see things sharply and clearly is the best with a monofocal lens. A multifocal lens has multiple points of focus, basically for far away and also for intermediate or near. Now, these lenses reduce the need for reading glasses, and you can see the picture on the right here. There are these sort of rings in the lens itself, and that helps to, it basically splits the light. So some of the light coming in your eye comes from far away, some of it comes from up close, and so that gives you the ability to see both far away and up close. But like with many technologies, there's a trade-off here. So this lens reduces the need for reading glasses compared to a monofocal lens, but it does have an overall lower quality of vision. The contrast is less, the colors will be less bright, And then there's also the possibility of getting glare around lights and halos around lights. And so patients who drive a lot, for example, especially if they drive at night, probably not a good option to go for a multifocal lens. But some patients, they really don't want to wear reading glasses, and they don't do activities where the glare and halos would be an issue, and they don't mind if the vision's not perfect, as long as they don't have to wear reading glasses all the time. And so for them, this is an option that, you know, can work very well. So again, monofocal, multifocal, there are other types as well that are sort of in between, but this gives an idea of the type of choices that there are available. So that's my cataract surgery or cataract portion of the talk. Does anyone have any questions? I do see a question in the chat, which I'll address, but anyone have any questions that they'd like to ask at this juncture?
Yes, are lenses always the same size?
Generally, yes, they are the same size in terms of dimension, but the power of the lens, how much strength is there or focusing ability in the lens, that is based on the shape of the patient's individual eye. So when you go to your ophthalmologist, they will measure the length of the eye, the curvature of the front of the eye, and some other things to determine what exact lens power, you know, would be best for your eye. So the lens power varies, but the lens size itself, you know, the overall dimensions are fairly standard.
Tell me, is there any way that cataracts could be prevented or their progression be slowed down?
That's a good question. I would say that the things that we know make cataracts progress faster, maybe avoiding those, you know, would be a good strategy. So for example, we know that uncontrolled diabetes will cause cataract to progress faster. And so having good control of the diabetes, good control of blood sugar is one way to prevent cataract progression. There are types of cataract that are likely related to sun exposure, so exposure to ultraviolet light. So wearing sunglasses, wearing shades that block UV rays is probably another good strategy. And then other factors, I think, you know, there are some other ones based on systemic health and systemic conditions. I would say that like many other things that are good for your heart and your brain are probably also good for other parts of your body. And I don't know that I can verify it, but I would venture that leading a healthy lifestyle, eating a well-balanced diet with lots of fruits and vegetables and getting exercise may possibly help with cataract progression. We see, I think diabetes is the main thing, but I see so many young patients in their 50s who have very advanced cataract, and they have very uncontrolled diabetes. And so I'd say that's a very important one, at least in my patients. But yes, that's a great question.
I have a question too.
Sure.
I have Fuchs dystrophy and I have cataracts, and my eye doctor said that I would probably need cornea transplants if I had the cataract surgery, and I'd have to lie on my back, and I can't lie on my back. So if you could address those issues at some point today, I would truly appreciate it. So I have a difficult time seeing, and I've had a number of falls partly because of that. Oh, I'm also 86, and I'm wondering at what point will I be too old to have these surgeries?
Yeah. So Fuchs dystrophy, you know, we can discuss that at some length, but Fuchs dystrophy, as you may know, causes can cause swelling in the cornea. So I don't know if you have swelling in your cornea, but the cornea is the window in the front of the eye. And anytime you do surgery inside the eye in someone with Fuchs, excuse me, especially if there is already swelling in the front of the eye, the swelling can get worse. So there are situations in which people have Fuchs where I just do remove the cataract and don't do anything else. And we cross our fingers and hope that the cornea doesn't get swollen. And there are other situations where I will remove the cataract and also do the partial thickness transplant for Fuchs. And it just depends on the individual circumstance. So, you know, without knowing more about your individual eye health, it's hard to give you a recommendation. But the consideration, one of the main considerations in my patients with Fuchs is, and if they also have cataract, is does the cataract need to be removed by itself, or does the cataract need to be removed and an additional procedure be done at the same time? Generally, there is a requirement after that type of procedure, after a transplant procedure, for Fuchs to lay on your back for a period of time, but it very much depends on the individual situation. There are situations where you don't need to do that, or that can be avoided in individual cases. And in terms of age, you know, there's no age cutoff. You know, I operate not too infrequently on patients in their 90s, but I will say that my preference or recommendation is to try to get the cataract out when your overall health allows it. And so, you know, for people who are getting into their mid 80s, I often recommend and say, you know, probably good just to deal with it. And because if we wait 5 years, it might be harder for you to undergo surgery because of other issues affecting your general health that may come up. And the anesthesia doctors may not want to give you as much anesthesia and things like that. And so, so again, it's very individual, but you know, I operate on patients who are in their 80s every week. So, so you're not, you'd still be a candidate for surgery, certainly, not atypical.
When you do surgery, what kind of anesthesia, how much anesthesia is there? Are you totally out?
Yeah, generally it's just sedation through an IV. So you're given some relaxing medication, kind of like a colonoscopy. So you're technically awake. Some patients do fall asleep, but you're technically awake most of the time. You hear, you know, you hear the surgeon talking. In my room, we always have some light music playing in the background. So patients, they're kind of aware, but they're okay with the fact that the surgeon is working on the eye. It takes off the edge, takes away the anxiety of having that surgery done. And the eye is numbed with local numbing medication. So you still feel some pressure, but sharp pain should be eliminated.
Dr. Farooq?
Yes.
Yeah, hi. My name's Rebecca West. I'm one of your patients, and I'm waiting to get cataract surgery right now. And you recently recommended that I see a glaucoma doctor also, and I just wondered, is that standard or specific to me?
Yeah, so I would say it's not standard to need to see a glaucoma doctor, but there are certain situations in which I do recommend for patients to see a glaucoma specialist. And that includes if there has been an elevation in the eye pressure, whether or not there's been any other sign of damage, just elevation of eye pressure itself can be a good reason to get an opinion from a glaucoma specialist. And also if there are signs of actual glaucoma in which the optic nerve in the back of the eye has some signs of damage. So in either of those situations, I often have people see a glaucoma specialist. I also treat glaucoma, but usually it's mild glaucoma. But there are individual situations in which the degree of glaucoma, the staging might affect the plan for surgery, for example. So in those cases, a glaucoma specialist opinion can be very valuable.
Okay. Thank you.
Does
Welcome.
having dry eye affect whether you can have cataract surgery?
Yeah, that's a great question. You know, dry eye is very common, and I would say that mild dry eye doesn't typically impact my plan for cataract surgery, but someone that has moderate to severe dry eye, we definitely want to address that first before pursuing cataract surgery. One of the reasons for that is that we, as as I mentioned earlier this morning or this afternoon, we get measurements of the eye. So we measure the length of the eye, the curvature of the cornea, which is the front part of the eye. So when the front of the eye is very dry, that can affect the measurements that we get. And so the measurements might not be as accurate if the eye is very dry. And so once in a while, I'll see a patient who is seeing me for a cataract evaluation, and their eyes are very, very dry. So I say, you know what, let's do these things to treat the dry eye aggressively. See me back in 4 to 6 weeks, then we'll see how the dry eye is doing. And if the dry eye is better, then maybe we can get the measurements for your eyes at that time. And sometimes when we treat the dry eye very aggressively, their vision gets better and they decide that they don't need cataract surgery. So I think, moderate to severe dry eye can impact the plan in terms of what steps are taken and at what time.
Thank you.
Okay, any other questions?
Yeah, I have a quick one in terms of causes. I mean, you talked about like UV light exposure or diabetes and such, and perhaps some genetic predisposition, but also, I mean, as in my own case, my understanding also just people who are severely myopic, I guess, near vision could develop it a little earlier than in life. And is that, I mean, I don't know if you could just address that a little bit about why that might be the case.
Yeah, it's not as robust of an issue in my practice as the diabetes issue, but one of the things that may impact that is that there's this term oxidative stress that gets used for various things, and there are free radicals. So free radicals are things in the body that can kind of cause a little bit of haywire where they go. And people who are very, very nearsighted, the jelly in the back of the eye, instead of being more of a compact solid-like jelly, it becomes a little bit more liquid sooner than in patients who are not as nearsighted. And so one thought is that those free radicals that are present way in the back of the eye at the retina, those might come forward toward the lens a little bit more easily if that vitreous jelly is more liquid. And so that may impact the lens. We know this also from patients who have surgery in which the vitreous jelly is actually removed. So if someone has a retinal detachment and the retina has to be fixed and the jelly is removed and replaced with saline, for example, those patients get a cataract very quickly. Almost all of those patients get a significant cataract within 2 years of the surgery. And so I think the nearsightedness issue is a sort of a less aggressive form potentially of that phenomenon.
And when your patient sees you, who really decides that the surgery is now? You or the patient?
I think that if you went to 5 different ophthalmologists, you'd probably find a slightly different way of approaching the issue. You know, some physicians may be, and I think all of them would fall into, you know, they're all appropriate or ethical ways of handling it. But my approach is, unless it's an emergency, I put the decision, I have the patient make the decision, because I really, you know, I can make my recommendation. I would say, I can say, if you were a family member or if you were my parent, I would say, yes, go ahead, but it's your decision. And so, because it's so individual what the impact of a patient's vision is on their quality of life. And, you know, a 15 or 20-minute visit with me in the office, I get a sense of what your life is like at home, but you are the one who lives it on a day-to-day basis. And so I tell patients that they are the best judge of what their experience of their vision is. And I think that some ophthalmologists may say, you know what, this cataract is affecting your vision and you will most likely do very well. So I think you should go ahead and do it. And I think that that's okay too. You know, the outcomes from cataract surgery are quite good. Yes, there are complications, but they are rare. I just think that there are a lot of things I don't know about a patient's life, their home situation, if they have to take care of someone. You know, there are a lot of factors that go into a decision to have surgery. And this is not like, in my view, like open heart surgery, where the doctor says, you really need this you know, to stay active or to stay alive. You really need this. This has to happen as soon as possible. This is more so a quality of life issue in most cases. And so I think that the patient should certainly be involved in the decision-making process.
Thank you. If you've had one surgery, what are the percentages that you have to have the other eye too?
Yeah, again, it's individual. So I would say in most cases, cataracts occur and they're pretty equal in both eyes. There can be some asymmetry, but I do tell patients that these are 2 individual decisions that you're making. A lot of patients, I'd say the vast majority of them, decide to have both out. We don't do them both at once. Typically, we do one and then the other. Oftentimes, they're about a month apart. But it really depends on the individual circumstance. Sometimes one cataract is a lot worse and we remove it and the patient says, you know what, I'm really doing fine. So we say, okay, come back, you know, see me when the other eye is causing you trouble. But I would say probably about 75% of the time we schedule one eye and then the other eye is a month later. And so we just take care of both.
Do you have a general preference or recommendation as far as getting either multifocal or monofocal And also, do you think most of your, if monofocal, do most of your patients then prefer to do like a monovision with different prescriptions in each eye?
Yeah, that's a good question. I would say I don't do a lot of multifocal. I think it just a lot of it depends on, you know, the practice setting and what patients are looking for and what they're asking for, what their vision needs are. Maybe I don't do a good job of, you know, sort of selling the multifocal to patients and saying, oh, you won't need reading glasses as much. I think that I kind of am a little bit biased toward the monofocal because the quality of vision is the best. And I ask patients, like, you're gonna wear reading glasses, do you mind that? And most patients say, oh, I don't mind, I wear reading glasses now. And so they like the idea of improving the quality of vision as much as possible. Sometimes what I do is what's called a mini monovision. So it's a less offset, but one eye is for distance and one eye is just very, very slightly nearsighted. And that increases the range of focus a little bit, but not so much that you feel a big disparity between the two eyes. If you were to close one eye then the other eye, you won't be able to tell that big of a difference, but it also kind of increases your range of focus a little bit so that, you know, hopefully you can see the dashboard while you're driving, for example, things like that. So most of my patients have a monofocal. Sometimes we do a little bit of an offset if they're really want to reduce their dependence on reading glasses, but there's trade-offs to everything. Even doing a monovision or mini monovision, there's some trade-offs to it in terms of, you know, your depth perception and things like this. And so I'd say the majority of patients choose to be sharper for far away, and they'll just throw on readers, and they'll have a few readers around the house, and they're satisfied with that.
For the mini monovision, what's like the difference in the diopter? Like a quarter point, a half a point, 1 point?
Yes, yeah. So for example, we might do like a minus 0.25 in the dominant eye, and in the non-dominant eye we might do like a minus 0.75 or a minus 1. So it's a small amount of nearsightedness, but it's enough to increase the range of focus a little bit. Okay, any other questions so far? Other questions for the moment? Okay, so I have quite a few more slides, and so we can either keep talking about cataract, and I can come back another time to cover the other topics. I don't know that I can do justice to glaucoma and diabetic retinopathy and macular degeneration. Maybe what I'll do is I'll kind of skip ahead to macular degeneration and just talk about that briefly, since that was one of the listed topics. So macular degeneration is also known as age-related macular degeneration, or AMD or ARMD. It is characterized by drusen, which are yellowish debris or deposits under the retina, and you can see in this photograph. So this is a photograph of the retina, and so there's an optic nerve, which is a round yellowish disc. There are these red squiggly lines coming from it. Those are blood vessels, both arteries and veins. So the arteries are actually the narrower of the red lines, and the veins are the thicker squiggly red lines. And then you might notice to the right of the optic nerve there are these yellow splotches, dots that are present, and those are drusen. So this is a photograph of an eye with macular degeneration, and this is what an ophthalmologist will see when they look at the eye after dilation. There are two main types of macular degeneration. One is dry and one is wet. And so dry macular degeneration is characterized by drusen, as well as what's called retinal atrophy. So atrophy, think of it as a sort of getting weaker. So a muscle will atrophy if you don't use it. So somebody who's lies in bed in the hospital for 2 weeks and doesn't get up, and then after that, they get up and they try to walk, they'll feel weak because their muscles atrophy a little bit during that time that it was resting. And so the retina kind of gets a little bit weak. You can understand it like that. So that's dry macular degeneration. And this photograph, you can say, is likely a dry AMD patient. Wet macular degeneration, there is actually fluid under the retina or sometimes within the retina. And usually there's some amount of bleeding as well. And so there are blood vessels in areas where they're not supposed to be, and that is what causes wet macular degeneration. This condition is the most common cause of blindness in the Western world, and about 2 million people in the United States are affected. So apologies for the quality of these photographs, but the image on the left is dry macular degeneration. You can see possibly some yellowish dots that are drusen. And then there's an area that looks kind of yellowish, that's a larger area. That's an area of retinal atrophy. So you're actually kind of seeing through the retina to the things that are underneath the retina, and that's due to atrophy. And then wet macular degeneration, in the photograph on the right, there's a hemorrhage there, there's a bleeding spot. And so that's an indication of wet macular degeneration because there's blood or fluid either within the retina or under the retina. So how is macular degeneration diagnosed? Your ophthalmologist will dilate your eyes and they'll look at the retina and see if there are signs of these drusen, which are these yellowish spots, atrophy of the retina, or if there are any hemorrhages or bleeding spots in the retina. And then there's also something called an optical coherence tomography, or OCT. And an OCT of the retina provides an image, a cross-sectional image that actually allows your ophthalmologist to see what's happening in the retina in every layer, to figure out, what is going on. Is there any fluid there? Are there drusen, etc.? So how is macular degeneration treated? Well, for dry macular degeneration, there's no medical or pharmaceutical treatment that's currently available, other than a specialized formulation of vitamins. So there are these things that are over-the-counter, AREDS vitamins or AREDS 2 vitamins or I vitamins. Those are, there are special formulations based on a clinical trial that was done that found some benefit. And then there's, for wet macular degeneration, generally there are injections into the eye. The eye is completely numbed and this medication is delivered, and that helps to get rid of the fluid. I will say that a colleague of mine who's a retina specialist, her research on macular degeneration is suggesting that a healthy diet, especially a diet that's that mirrors the Mediterranean diet, or has very minimal or no meat and has lots of fruits and vegetables and nuts and things that have a lot of vitamins, minerals, and proteins, may help in macular degeneration. But that research is ongoing. And I think her take is that there's no downside really to eating a healthy diet. It's good for your heart, it's good for your brain, and it's probably also good for your eyes. Okay, so I kind of went a little bit quickly through macular degeneration. I appreciate all the questions on cataract. I know that's a big topic. Any other questions at this time? think Gloria, you're on mute.
No, we lost her. Well, while Gloria is getting oriented, one of the issues I have, I'm a regular patient at U of C, but I was taking medication a number of years ago for bladder irritation. And now we've discovered that there are consequences to that medication. It's affecting the retina. Does this happen often, that medications for one part of the body, then later on we discover are affecting the eyes? Or
There are not a lot of medications that do that. I think there's a medication called pentosan sulfate that is used for the bladder that can cause retinal changes.
Yes.
So there's that medication, and there's also a medication called Plaquenil, which is the generic is hydroxychloroquine. And that medication is used for autoimmune diseases like rheumatoid arthritis and lupus and things like that. So that medication can cause retinal toxicity, and many ophthalmologists will monitor patients who are on these medications to check for any early signs of toxicity. And so there are not a lot of medications that do that, but there are some that can cause either retinal or optic nerve issues. One of my areas of interest is there are new chemotherapy drugs that can cause changes in the front of the eye in the cornea. So the cornea is sort of one of my area of focus. And so these new chemotherapy drugs, while they can be very effective in treating many types of cancer, can cause vision issues related to drug being deposited in the front layer of the eye. And so that's something that I've been interested in and have worked on. So it's not a long list of medications, but there are some. And as ophthalmologists, we are seeing more of this because there are new drugs being made, and so there are new observations that are made along the way. Yes.
What I wanted to ask is there a good source of information about the things you've been talking about? I need a little more information about some of them. That's one question. And the other is, do you have appointments available for second opinions?
Yeah, so for the first question, I would say if you want to find a reliable source, if you're looking online, whatever the condition is, you can type in, so say cataract, you can type in cataract followed by American Academy of Ophthalmology. So if you type in cataract, American Academy of Ophthalmology, you should find, here, let me, just want to see if I can pull up something here. So let me see what happens if I do that. Cataract, American Academy of Ophthalmology. Yes, okay, so I will share my screen again once it's loaded up. And okay, so I in Google I typed in cataract and cataract American Academy of Ophthalmology, and there's a page that answers the question, what are cataracts? And talks about vision problems, clear lens, cloudy lens. There's a video, goes over symptoms, causes, slowing down development of cataracts, so some of the questions that have been asked here, and cataract surgery. And there are other, so you can go to the next page. So the American Academy of Ophthalmology is sort of our umbrella organization. and the information on there should be felt to be verified as accurate. Yes, I'm happy to see you or anyone as a patient for a second opinion. So again, my areas of expertise are cornea and cataract. And I have very good colleagues who do the rest. But yes, I do see patients for a second opinion fairly frequently.
Sounds good. I think I need one because I'm at an end, like the doctor has nothing more for me to do for the Fuchs plus the cataracts. Since I can't lie on my back, you said there might be some other way of treating the problem. Like I think if I could get knocked out for the day, I might be able to lie on my back, but there's too much pain to be awake and do that.
Understood.
Great.
With regard to the Mediterranean diet, do you know if that research has found that to be preventative or mostly sort of a treatment progression thing?
Yeah, I mean, I think that my colleague, her research so far is mainly in animal models, so like a mouse. So she's given the mice different types of food, different types of diet, high fat diet versus a low fat or no fat diet, for example. And she's found pretty substantial differences in the rate of retinal changes. And so I think at the moment there's sort of extrapolation to what likely happens in humans based on the laboratory evidence and also what we know about how macular degeneration develops and what happens at a cellular molecular level. But yeah, I think it's probably more so preventive, but hard to know at the moment, but there may be some beneficial impact for patients who already have the diagnosis. I think it's just too early to tell if it will be a meaningful difference. But again, it's sort of unless you really, really love hamburgers, it's sort of there are not too many downsides to having a healthy diet.
Hi, this is Rebecca West again. I had a question about macular degeneration. My partner has had it for quite a while and was getting injections. Okay. In the last week or so, all of a sudden, he really just can't read anymore. And it's just this really sudden change. I wondered if that's common. He's going to go see Dr. Skondra very soon about it, but it's just kind of shocking how sudden it was.
Yeah, so a sudden change in vision for a patient who has macular degeneration may be indicative of a new fluid or leak or a bleeding episode that can cause that shift. So yes, any sort of sudden onset of decrease in vision when there is, in general, when that happens, see your ophthalmologist. But in macular degeneration, it can be an indication of a shift, whether it's some bleeding or fluid accumulation under the retina or in the retina. So that would be what the retina specialist will be looking out for.
Okay, thanks.
Well, it is 1 o'clock, and I thank you for the discussion. And I think most of us have had cataract surgery or are looking forward to it. We are of that age. And so I think that was very helpful. And some of the other issues, it might be good if we could contact you in a later date, have you come back. But I think for a U of C doctor, you've spoken very clear English for us. A language we could understand. So we appreciate that.
You know, that practice comes from not just seeing patients in clinic, but family members and family friends who ask
That's
questions where you know, there's sort of I'm sitting in the living room, so it's not like I'm running from place to place. So they, you know, they sort of ask all the follow-up questions. I think it's my pleasure. Hopefully it was clear enough to
Very.
you know, answer some of the questions you may have had before.
Although I do want to say, as a U of C patient, I was very glad that the doctor I was seeing kept up on his reading and discovered this problem with the medication I was taking, because it's brand new. So, and they have answered my questions, and I'm seeing the retina specialist. So I feel like I'm being taken good care of. So give you a little plug there. But I want to thank you very much for the discussion and the
Yes.
information.
Yes.
And I think Laura is going to take over for general conversation, and you can hang around, or if you need to get back to things, we just thank you very much.
Yes. Thank you.
So much, Dr.
Thank
Okay.
you.
Thank
you
you.
very much. Yeah, it was nice to spend some of the afternoon with you folks. And I do have another meeting starting soon, but
Right.
yeah, I'm happy to, you know, I have the slides already made, and
Yeah. Yeah.
so if
Let's
there's
do it.
any time
I'd love to have you.
to cover those other two topics,
Right.
Okay. Well, we
That'd be
will
great.
be talking with you. Thank you very much.
all right, you're welcome. Have a
Yeah.
great day, everyone.
All right.
Thank you.
Bye-bye.
Aye.
I